Hello and welcome back to part 2 of our series on COVID-19 and the older adult. I'll now hand you straight over to Dr. Charles Inderjeeth, and he will speak about medication and research. Dr. Inderjeeth, over to you.
Thank you, Rick. In this section, I'm going to cover the role of vaccinations, infection control, medication management, some future research, and some useful websites and resources for people to contact. Firstly, in terms of current medications in those who are well, this is an important question, and it's important to realize that the medical advice is that you do not stop your medications if you are well. You should not change your medications unnecessarily as well. We should remember that the COVID-19 pandemic may last many months, and medications for disease control and to reduce flare and progression is essential. Otherwise, the risk of disease progression or complications may increase the risk of getting other complications and the risk of morbidity and mortality. We do not recommend even stopping immune or rheumatology type medications. In terms of prednisolone and steroid therapy, stopping these suddenly may result in people becoming quite unwell. And in that situation, higher doses may be required to control the disease, which may put people at even higher risk. Instead, if people are at risk, they should reduce the risk of exposure and should socially isolate more diligently than they otherwise would. And if you're on immune modulating medications, and you do have close contact with a COVID-19 affected patients, I would recommend you discuss it with your GP or specialist about delaying or modifying your treatment, which may be feasible in some circumstances with appropriate action. So what should patients do if they're sick, however? If you have a fever, sore throat, shortness of breath, or cough, it's important that you call the medical practitioner or the clinic in advance to let them know that you think you might have symptoms relevant to the condition, so adequate precautions can be taken and you can be given appropriate advice on the best process to follow. If you need information, then contact your GP or practitioner, and the National Coronavirus Health Information Line 1-800-020-080 is an appropriate service to contact. If you're acutely unwell, however, remember, you will need to call an ambulance as you normally would in an emergency, because delays can result in worsening of your condition. You should always inform practitioners if you are on immunosuppressive medications that may increase your risk of complications. In patients who develop significant infection, you should consult your specialist about your immunosuppressive therapy, even if you're not unwell enough, so that this can be reviewed and modified if appropriate. As mentioned earlier, that it is not appropriate to abruptly stop steroids or prednisolone because of the risk of flare, and patients sometimes get dependent on prednisolone and require this for other reasons as well. If you have any questions about immunosuppressing medications, I would recommend that you contact your prescribing specialist for specific advice on the risks versus benefit of continuing the treatment versus cessation. The question we often get asked is, what about other vaccinations? Now, we know that there's no COVID-19 vaccine yet, and we hope that there will be one in future, but it's important that we keep up to date with vaccines that are currently available. With the imminent flu season coming up over the autumn-winter period, it is important that people have their flu vaccinations, which is highly recommended, because this condition has a similar presentation as COVID-19, and it will be difficult to distinguish between the two. It's important that we take one condition out of the equation if possible. And patients often do worse if they have a combination of two different viruses or a superimposed pneumonia. Which leads me on to the second point, which is you should consider pneumococcal vaccination if you are susceptible, and you should discuss this with your GP or specialist. And some patients may qualify for the zoster vaccination, especially in older populations. So the intention is to reduce the risk of other diseases or infections that have a vaccination available, so you can minimize the risk of getting more than one infection or causing confusion with regards to what your presenting problem may relate to. So what about chronic care appointments and blood tests? Routine care of chronic medical conditions should continue unchanged, although there may be some modifications to your attendance routines. It is important that you have your blood tests because there are good clinical and medical reasons for safety to monitor your disease, as well as the complications of some of the treatments that you may be on. For example, methotrexate in rheumatoid arthritis and the risk of bone marrow and liver abnormalities. There are now Medicare rebates which make it easier to have your blood collected at home, and some pathology services do offer a personal attendance appointment slot where it minimizes the risk of you coming into contact with other people. There's also the option of medical review via the phone, or what we call telehealth, and there are a number of new COVID-19 bulk bill Medicare items that are available to enable this process. In terms of physical therapies, some of these can be supervised by video conferencing. However, not all physical therapies are avoidable, and if essential and there's no alternative, diligent precautions need to be taken by both the patient and the healthcare worker to reduce the risk to either of you. So in summary, we have the option of face-to-face consultations with some restrictions and precautions, and we have the option of telehealth where face-to-face should be absolutely avoided and telehealth is feasible. There are special item numbers. This could be done by telephone consults, by video consults if visual images are required. There are some limited home visiting services with appropriate precautions. And of course, we can always default to face-to-face GP specialist or clinic consultations if required, and a physical examination is essential to your well-being and health. So what are some of the symptoms of COVID-19? The virus will affect individuals differently, and the majority, up to 80% of people, will experience a mild flu-like illness, which involves fever, flu-like symptoms like coughing, sore throat and fatigue, or shortness of breath. We should remember that even if we have mild symptoms, we can still spread the virus to others, and all precautions need to be taken. In terms of treatment of mild symptoms, this is like we do with the flu virus or other upper respiratory infection. It is mainly symptomatic and involves rest, hydration, nutrition, and antipyretic and anti-analgesics. There's been some controversy relating to ibuprofen, and the National Prescribing Service have indicated that if it has been taken previously to treat fever and has provided relief, then the current advice is that it is appropriate to use this medication. It is generally not recommended for people who may have other risk factors, including asthma, those who are pregnant, particularly in the third trimester, those with chronic heart disease and impaired kidney or liver function because of the risk of toxicity to some of these organs. In addition, patients with stomach ulcers or gastrointestinal bleeding should avoid these drugs for those reasons only. Currently, there is not enough robust and direct evidence to suggest that ibuprofen worsens COVID-19 outcomes. However, I'm sure we will be kept informed should there be any yellow or red flags in future, but at the moment it appears to be reasonably safe in the appropriate patient. What about more severe symptoms? Now, people with fever, cough, and other symptoms should seek medical advice early, because early intervention results in better outcomes. And up to 20% of patients with COVID-19 in some populations have been hospitalized, usually with the serious effects of the condition such as pneumonia. And people at particularly risk of severe disease are mainly the high-risk groups that I described earlier on. And 5% of people who get COVID-19 infection will end up in an ICU based on the international experience. And they often have serious symptoms such as difficulty with breathing. These patients are called 000 for urgent medical help should they occur, and inform them that they think they might have COVID-19, so that adequate precautions may be taken to protect all of those involved in the transfer of care. Now, how do we diagnose COVID-19? Now, the only test available at the moment is nasal and pharyngeal swabs, where we look at PCR, and this test result is usually available within about 24 hours. It is also important for follow-up of patients who may have had the infection, in terms of whether there's clearance of the virus to make it safer for them to return to the community and other contact with the usual precautions of personal distancing. There are a number of antibody tests in development and some are currently available, but these tests are only really useful to assess whether a person has previously had the infection and whether they develop antibodies. It may provide evidence for prior infection or immunity and may provide us with a means of follow-up in terms of the durability of this immunity as well. These are subject to ongoing research currently. There are a number of other organ systems that can be involved in patients who have COVID-19. Apart from fever and dyspnea and sore throat, they can have chest pain, they can have muscle pain, or the myalgias that we see with other viral infections. Between 3 and 15% get some cardiac involvement called myocarditis, which is initially usually asymptomatic but can progress, and it's important to monitor this. About 5% of people will get diarrhea, and it's important to be aware that not all patients may have respiratory symptoms and can present simply with diarrhea. And a number of tests are useful in assessing patients for the extent of the disease and progression, including chest x-rays, CT scans, which, if they show abnormalities, are a sign of more severe disease that warrants more active and early intervention to reduce the risk of progression. So some of the treatments in trials and some of the cautions with these. Now, there's been a lot of media on this, and a lot of hype, and some irresponsible politicians have recommended universal use of some medications without scientific proof. So it's important to get good medical advice before you make a decision on any treatment. Most patients simply require a supportive care for mild disease. Those who are sick or have pneumonia are often treated with oseltamivir, which is a medication for the flu, until influenza is excluded as a diagnosis. Sicker patients are often covered for possible bacterial pneumonia with ceftriaxone and azithromycin for approximately 72 hours. And thereafter, a decision is made on appropriate antibiotics depending on the findings. There are a number of experimental treatments, and I have to emphasize that the benefit of these agents are unproven at the moment and are not without harm, and should only be used in the trial setting under appropriate supervision of your medical team. A number of antivirals, including those that have been used for the hepatitis viruses, have been tried in the past for other COVID infections. They've also tried retroviral medications, and more recently, both of these classes of agents have been trialed in the Chinese setting and subsequently in some of the European settings for COVID-19. At this stage, there's no evidence for definite improvement or benefit, and they remain trial drugs used in trial setting with appropriate monitoring of benefit versus risk. The other agent that has had a lot of press is chloroquine and hydroxychloroquine. It has been called a game changer. It is not at this stage. It is currently under a trial in a number of countries, including Australia, and it's important to remember that it is not without risk. And important considerations are cardiac long QT intervals can result in significant arrhythmias, and of course there is a risk of retinal damage in those who are susceptible and those who require higher doses for longer periods of time. If you are on hydroxychloroquine for your current medical conditions like lupus or rheumatoid, the recommendation is that you continue. There may or may not be a benefit in terms of coronavirus. There does not appear to be a significant increased risk, as you have already been recommended this treatment. The other class of agent that has been looked at are the ACE2 receptor blockers, which are used in hypertension. At this stage, there's no definite benefit for benefit or harm in these patients. And I would recommend that if you're on an ACE2 receptor antagonist for your hypertension, that you continue your treatment. Hypertension is a bad complication in patients with coronavirus, and adequate control of blood pressure is important. Steroids are used in some settings, although controversial. It has been used in a number of the settings in China, but less so in some of the European settings, and often for lung swelling and or what we call edema of the lungs. The evidence for its benefit is still under investigation. There have been some newer treatments, for example, blood plasma transfusion using the antibodies from patients who previously had the infection with antibodies, and there are some case reports, and it is speculative about whether this will be useful going forward. There's also been cohort studies or use of IL-6 blockers, which are used in rheumatoid arthritis, for example, as well. for what we call the cytokine storm release syndrome, where patients become quite sick in some of the Chinese centers. However, there are no randomized controlled trials as yet. Hopefully, there will be more data available in due course. There's also a lot of discussion around the use of BCG vaccine. This vaccine has been used in the past for immune enhancement and for some cancers, for example, bladder cancers. At this stage, it remains experimental, and if you wish to consider being in a study involving BCG vaccines, there is one currently ongoing at the Charles Gardner Hospital and maybe at other hospitals as well. However, it is not recommended routinely in the population, except for some younger patients and those traveling to countries where there may be a high risk of exposure. And of course, as part of treatment, early treatment and intervention and oxygen support are quite important. And in those who have difficulty, the use of mechanical ventilation early is advocated before the complications are too far advanced. There is some debate around non-invasive ventilation and the risk and benefit, and in terms of whether it will be useful and whether one should simply proceed to mechanical ventilation. This is under study currently as well. So I put the slide up mainly to demonstrate the magnitude of the problem that we're actually dealing with. There's almost an equivalent number of males and females involved. It often occurs in people who have traveled, and most of the cases in Australia have been in travelers returning from overseas and from cruises. But importantly, in the European studies, about 91% of those afflicted have recovered. And most worrying is that about 10% of healthcare workers have been affected. 10% of those affected are healthcare workers, which puts a significant strain on healthcare resources. And in some centers, 1 in 4 healthcare workers have been afflicted. About 39% have been hospitalized in the European countries, but in general, we expect that around about 20% of those affected by the coronavirus will be hospitalized, and about 5% will end up in intensive care, with about half of those resulting in mortality. In terms of death, the important thing is that all ages can be affected. And you can see the range of ages affected and dying in Europe between the age of 27 and 100. What's important is that underlying comorbidities and medical conditions were present in 83% of this population, confirming that those who have comorbidities are at highest risk of succumbing to the disease, and the importance of actually taking extra precautions in this group. So why are we trying to flatten the curve? So essentially, without intervention, and you've all seen numerous graphs or similar graphs, and this is from the CDC. Without intervention, you can see a significant peak in the early infection rate, which will overwhelm the healthcare system, which is in the broken line there. And what we're really trying to do is to reduce the number of cases below this critical line to allow us to be able to provide adequate medical attention for anybody who might be affected. And that is the only way that we can actually prevent unnecessary deaths or prevent what we call preventable deaths. And the moment we're doing extremely well, where we've reduced our rate of increase on a daily basis from 20% down to 2%, which is an extremely slow rate. And with that, we do have the issue of what the longer term impact will be in terms of maintaining personal distancing and lockdown, and what impact that will have on the economy and other parts of our life. To end on a positive note, what have we learned from this current outbreak? Importantly, I think it will teach us good habits, and we can expect that there may be less influenza because people will be more diligent with their vaccination, more diligent with personal distancing. There'll be less respiratory and diarrheal illnesses in future if we comply. We have become more aware of the importance of infection control. It will change our behavior and risk management. It has taught us the importance of personal and environmental hygiene. We should look at it as you protect me, I protect you. So I will do the right thing and you should do the right thing as well. It's important that we isolate when infectious, because we do not want to spread the bug to other people around us. Vaccination compliance is extremely important for other conditions, for preventable diseases, to avoid compounding the problem and the burden on our healthcare systems and increasing complication rates from dual infections. We need to protect those who are most vulnerable, including the old and the frail, and importantly, those who are susceptible, including healthcare workers. Hence the importance of adequate PPE and other precautions in our healthcare community. We need to minimize unnecessary personal and physical contact. And I think there's often a debate about the risk we put by actually keeping people in isolation in terms of their mental health, but older people in residential care facilities. But what we have to do is look at the bigger picture, where we have to protect our older folk, protect other residents within the facility, and importantly, also protect the healthcare staff that may be looking after them. So we have to see the bigger picture in this context rather than the narrow view. We may need to think about new ways of greeting each other, because physical contact going forward may be less desirable than in the past. And there may be other ways of extending this courtesy. And I think it may actually make the world a better place, because we've already seen the benefits of this lockdown in terms of reducing pollution, improving our waterways, reducing unnecessary consumption. So it may change the way that we view life and become more responsible in terms of the environment, the world as a whole, and connect a lot better with people around us. And I want to show you what I call alternative ways for handshakes. Now, I can't get the graphics to work on this, but now we may need to stop shaking hands and consider the wave, the hand on the heart, the namaste as they do in India, the New Zealand greeting, the highbrow, and other greetings that may be more appropriate, that do not involve physical contact, but do not take away from the importance of being socially courteous, greeting people, and being social. And it actually brings me to this this image that was sent to me by a colleague of mine who mentioned Nelson Mandela, who was in isolation for 27 years. And he had no family, no luxuries of phone, just hope and a vision. And I'm sure we can do the same as well. We fortunately do have the luxury of some social and verbal contact and visual contact through media, which some people in the past have not had access to. And the world has been a better place for their presence. And I also want to finish with this poem by Kitty O'Meara, which I think more elaborately describes the important impact of the coronavirus, both on communities, people, social contact, and importantly on the world itself, and what a significant impact it is going to have in terms of our future and life, what it will reflect in terms of moving forward. So there are a number of sites that you can access for information and resources, including the Department of Health, the National Coronavirus Health Information Line, and a number of phone numbers that you can contact in states and territories. And if in doubt, there are a number of COVID clinics that are available throughout the metropolitan and rural areas that you can attend if you require information on screening and if you're concerned that you may have acquired COVID-19 infection. So I wish to thank you for your attention. This is the end of the second part of this seminar, and the third part will involve questions and answers from you to me. Thank you.
Thank you, Charles, for your presentation. And that was very useful and quite informative. We do have a number of questions now that have come in from our consumers, and we'll move on to that. And that is part 3 of our webinar series.